so that you don't cause skin problems and nerve problems. It's supposed to be a video, I don't know if it plays or not. Yeah, it is playing. Again, my setup, I have a clear drape to use. The monitor is at the foot end. You can't do hypotherapy without fluoroscopy. Don't tell me that people have done ultrasound, but you need some guidance, image guidance. And everything else is on the opposite side. I put a lot of traction, I internally rotate. I adduct the leg to cause lateral dislocation or translation. You feel a big pop of the head coming out. All the equipment is on the opposite side. Not too many instruments. About 13 instruments is all I need to do a complete FAI surgery, including labral reconstruction and repair. Right? Pretty sparse on the tray, not too much. Portal, there are a lot of portals described. You select the portal based on what you need to achieve, and I can do all FAI surgery through these two portals. An anterolateral with the fluoroscopy, this is under direct. Once I do the fluoroscopy the first time, I don't need fluoro again. I can do this portal under direct vision, control, and use fluoro only to look at my camera resection afterwards, to make sure that I'm spherical enough. A good technique to follow is, under fluoro, you push against the capsule, and if you're against capsule and not on the air orthogram, that means you're lateral enough that you're not going to be in the labrum, being so far away from the rim. Enter deep nicely. So that's not based on trochanteric height, it's based on what path gives me a deep penetration into the hip without causing problems. This is how a cam looks, right? That's not normal. A normal should be straight across like this. The head neck junction is extended like a bicycle helmet. And after you resect it, this is how it should look, a concave, a cam. I may take a few more minutes, Chairman, if you don't mind. So look at this. Nothing, right? That looks almost normal. But there's a little fibrillation. Some of my patients are 12 and 11 years old. So you don't expect a lot of damage yet. But I'll show examples. This is the earliest damage you can see from cam impingement. Then you push on that same person with a probe, that cartilage bubbles. That's not normal. That's chondromalacia or the stapler cartilage, right? And if you don't treat them appropriately, a few more years later, they get a flap like this, and then the flap falls off, bare bone gets exposed, and there's nothing you can do to save the hip afterward. Right? So prevent this, diagnose them early and treat them early. So cam on both sides, can do an osteoplasty. That's a little excessive than I needed, but there's an osteoplasty. This pincer, labrum getting pinched, right? In the cam, the labrum doesn't get damaged in the beginning. All it gets is separated from the stapler cartilage. Here it's getting pinched, the redness, and that's the frayed cartilage border. That's what the changes on the head neck junction from the labrum rubbing on it. That's mixed impingement. Pincer there, cam here, right? Very common. And the finished product is you do rim resection of the acetabulum, put the labrum back, the sutures, and then do the cam osteoplasty. These are patients with open growth plates. It's not a contraindication to do cam osteoplasty with open growth plates. Mild slip, skeppy. Mild slip that's impinging, right? You can put a screw in and wait for remodeling. The remodeling happens at the expense of this rubbing against the articular cartilage, right? This rough bone rubs, abrades against the labrum and acetabular cartilage, right? It's not the same as the early abrasion of the articular cartilage from that rough bone, right? So here, what you do is put a screw in and do an osteoplasty. So natural remodeling doesn't have to happen at the expense of labral damage. So contraindications, acetabular. Everything is relative. Indications of contraindications are relative. Once you get experience, most contraindications will go away and the indications expand. So none of these are absolute contraindications, but you have to be more careful. In the beginning, don't try it with these conditions. And complications, the top three are specific for arthroscopy. A lot of fluid can extravasate into the abdomen. You can do very common to iatrogenic damage in the beginning. Even now, occasionally, I can't promise you that I can do a scope without any iatrogenic damage. In the knee, I can guarantee you that I won't cause any damage. But in the hip, I cannot. The initial needle maybe goes to the labrum. Traction injuries if you pull too hard for too long. I don't know how far you let me do this, but I'll show you this video. Can you? So, a full case of hypotheroscopy. First portal was done with on a fluoroscopy. This direct vision. I put a needle in, putting a knife to do the capsulotomy. Right? Acetabulum, labrum, femoral head. No air was pumped in yet. No fluid is pumped in yet. It's a dry scope. Now fluid is in. Completing the capsulotomy from another portal. So once you get a wide capsulotomy, it's like an open operation through small incisions. right? It's not that difficult once you get the hang of it. Frontal head, labrum, vestibular cartilage, cutting the capsule, and you go more distally, you start seeing muscle fiber. That's the iliacus muscle. That's iliacus muscle, and the psoas tendon. That's my lower limit. I don't need to go any farther than that. Iliacus crosses around the 3 o'clock position. That's far enough for me for pincer resection. So that's the limit on the other side. I can fasten it a little bit if you guys want. I don't know what happened, what I did, but can you run the video for me again? Please? I didn't help at that. Can you advance it a little bit? Advance it a minute. Going back to capsulotomy again. So while capsulotomy makes it very easy. Once you open it up, the instruments go in and out easily. It's not a struggle anymore. Look at the labral damage on the patient. That's the labrum that's all folded in. That's normal. The stellate crease is normal. Oh, start it again. Advance it. Go to the middle.
Please conclude.
All right, I'll stop.
You can conclude. In conclusion,
radiological picture at which they present might be variable from a simple sclerosis to a lytic area to a collapsed area. We know the Fickett classification which puts into different brackets, and then depending on that we might have again a variation in the radiological picture when the patient presents to us. A classification which further defines 8% specific and 100% sensitive modality to define avascular necrosis. And if you want to know the prognostic value, looking at the curval angle into axial views gives us a better perception. If we look at the perfusion, it can give us the ongoing vascular status also. And then there are other papers which say, depending upon the enhancement, we can measure and we can know the outcome in these cases. But we must differentiate it from a nearby diagnosis of a transient osteoporosis with the same population type. This is our workup on 18 Freud PET CT, which is one of the first paper we did, and subsequently we did a series of these cases of doing it pre-operatively, then doing a decompression, subsequently following them. And what we found was PET scan as such is as sensitive as MRI, and especially advantage is that it can give us subsequent vascular status also after the treatment, which MRI sometimes is difficult to predict with MRI. And a very important, in the diagnostic criteria for avascular necrosis, look here, these are all investigations. Clinical features do not get into the diagnostic criteria. As I said in the first slide, clinical picture is variable. So it does not amount to any factor in the diagnostic criteria. They are all imaging based. Intraoperatively, we have done this aspiration and we have found it out that intraoperative, if you are able to aspirate a cc blood from the head, which you think ischemic, it is a vascular head. If the aspirate is less than that, it's likely to be a vascular head. Trauma is one event in which we know the day of onset, and if there is a dislocation, the question comes when the MRI will show. And it is again our perception that if we do take MRI after 3 months, we will surely be able to define out whether the particular patient has got AVN or he doesn't have got an AVN. Then we looked at our epidemiology in North India, we found it out. Steroid was the main cause, idiopathic subsequently, and alcohol consumption was the another cause in our patients, and 60% of the cases had bilateral problem. The question comes, how much of steroid? It is found that anything more than 15 milligram per day is definitely linked to AVN as compared to any dose which is lesser than that. Now, coming over, can we prevent it? Now look at the size of the lesion, as we said, in curval angle, or they say the volumetric assessment of the ischemic area. If the lesion is small, they may not progress. Otherwise, all lesion with carbon more than 240 degree progress to a further collapse in those things. Can statin therapy help? Yes, it was proposed that if in steroid cases we give statins along with, the chances are we may be able to prevent the avascularity. There are not very many studies, but at least there are some. Then pulse electromagnetic field stimulation has been done in rats. Simultaneously, they found if we do it, we can prevent it. This is the another thing which has been said about it. But if it has already been there, the question is, what is the current status of management? Does weight bearing increase it? If you look at this, weight bearing or no weight bearing, it does not matter in the progression of AVN. If it has to be there, it will progress. Non-putting non-weight bearing will not reduce and is not a treatment or not basically. Then people tried iloprost. They tried anticoagulants, and there are papers that for a specific pathologies, these agents may be useful, but again limited series in the literature as such. And then comes our very favorite bisphosphonates. Basically started from 2004 onwards as experimental studies, and then we have two clinical studies, one in JBJS and another in rheumatology from India. There is a very interesting concept about how this can be useful. They say osteoblast and osteoclast start operating if simultaneously. Osteoclast work within 3 months, 3 weeks, osteoblastic 3 months. So whenever two are simultaneously working in avascular necrosis, early osteoclastic work brings the weakness and the head collapses because osteoblasts are slow to come in. So by giving bisphosphonates, you are slowing down the osteoclast maybe to the level of a osteoblast, and maybe that is the reason of their effectiveness. But if you look at the literature review, when you see all these papers, I don't know whether you will be able to read it out, but if you look at the first 3 papers, they are from Sanjay Agarwala, rest paper, there are 4 papers, rest papers are by other authors. And when you look at this meta-analysis, this has supported that the bisphosphonates are useful in the management. Another meta-analysis in the same year did not include any of those papers by Sanjay Agarwala and concluded still there is a lack of strong evidence in supporting the application of alendronate in the management of avascular necrosis. Cold decompression. All meta-analysis says it is an effective management strategy. The current technique is not to make a big hole, but to make smaller holes by 3 mm, 4 mm or 5 mm. Stillman pins. Don't use drill bits because they are likely to break it out. So use Stillman pin to get compression, decompression in that area. Question comes, is it better than doing a restricted weight bearing? Yes, it is definitely. Cold decompression has got a better outcome than restricted weight bearing. The literature is clear about it. Then there is this evidence, I know Prashad might have seen this thing. They say if you do arthroscopy along with and define the lesion, probably the cold decompression gives you better outcome as compared to not doing without arthroscopy. And an interesting thing about post-traumatic avascular necrosis, there are no studies in the world as per this paper in 2015 regarding post-traumatic AVN. And further they said, in post-traumatic AVN, a low cold decompression is not effective. Then we published a study in 2017 of post-traumatic AVN, and what we found it out, while the rate of cold decompression success was 70 to 80% in non-traumatic AVN, it was just 50% in traumatic AVN. So it is not as good as we talk about in a non-traumatic AVN. Then people combine cold decompression with bisphosphonates. They feel it gives them a better outcome in this kind of a situation. What about PRP? There is only one very good paper which says still not adequate. Still research does not support it. We need more work to say whether it is useful or not useful. Then comes autologous bone marrow. As an orthopedic surgeon, bone marrow is always our favorite thing. And this in 2001 was the first publication ever on the use of this in PRP by Harnik, and he was subsequently paper. And this is the abstract which I read in 2002. And then one of my friend, an orthopedic surgeon, got a sternum fracture, got a dislocation, did it. I reduced it and I put AVN, and it said, I'll take and it said he got AVN, but it settled down. He got subsequent degeneration. He's with me for 16 years. It was useful. Then other papers appeared for as far as marrow was concerned, and then we had this study, a properly randomized controlled study with a proper fical layering, centrifugation, and all a proper protocol. These are some cases. This is one case, you can see bilaterally. This is subsequently after cold decompression. This is 18 months, and this is in 7 years after the surgery. Another case, 31 year with Hodgkin lymphoma on steroid. This is the cold decompression. This is subsequently 8 years later. She's maintaining the hips, though the degeneration is. Another patient operated in 2009. This is in 17. He maintains his hips. This is in 19. He still maintains his very well abilities. Another patient in 2007, one was very bad, one was okay. In bad we did THR, another side we did a cold decompression. This is cold decompression cells. She's in 2016 and now she's in 2019. Still that head is working very well after 11 years. Another patient with the same situation, one bad, one simple cold decompression, and this was in 2007, this is in 2017, still maintaining those hips with the avascular necrosis. This was a failure which we had at 8 years. So this is what we published in 2012, that these are useful. And then subsequently there were reviews. We also published our review of these cases. And then there are meta-analysis. These studies in 2014, studies, another meta-analysis in 2014, another is in 2016, another in 2017, another is in 2007. All meta-analysis, all have proved that these cells added to the cold decompression definitely increase the rate of success of these things. Then they cultured ones, and the culture one also we tried, and we found it gives a very early result in this kind of a situation. So the current guidelines do say that you should be adding these bone augments in all these cases. Then we try to see whether it is good in a stage 1 or not. But we did not find that in stage 1, when there is only edema, these cells are required. These are not required in stage 1. It's only in the stage 2 when these are really necessary. So I'll just go over to the other pathologies because of the time constraints. This is our result of vascularized fibula. Yes, this is another method which has been found to be, but it is technical oriented, so it cannot. Then there are another procedure, long vascular fibula, vascular iliac acid graft, and all those procedures have been tried, but with the time they have gone, because they are relatively technical, surgery oriented, so they have not been able to stay over there. But simple cold decompression, tantalum material, and this iliac acid graft have been used. The rotation osteotomy, the Suzuka one was used, but it was technically complicated. Now people are using cementation of femur head also. This has also been given as a study, but again not into use. And now these are new umbrella shell memory alloys, they are in use. So practically we will say that not many surgical options have been used, but if we look at less morphology, if the patient is in an early stage, less invasive cold decompression stays the management, along with you can give alendronates, and in advanced cases there are many surgical procedures which can be done. Thank you, sir.
Thank you. So you spoke about alendronate, that's oral. So is there any role for intralesional bisphosphonates?
Yeah, Dr. Prashad has his literature published on putting it inside the bones also, and then he says it is quite good.
Thank you.
Arthritis, true arthritis, there's nothing to save the hip, right? So I'm trying to tell you how to save hips when the arthritis is not too bad. How many of you will do total hip for this patient? Ajay? Total hip? 16-year-old. Will you do it now? so there's some issues, right? So total hip is not something you want to do take lightly. So this patient has some arthritis, but the abduction view shows improvement of cartilage space, right? There's some congruity there. So it's fresh out. I did it only 2 days ago. My host did not send me the final X-rays, but you can see the joint space is maintained, the head is well covered. There's a lot of correction I needed, but because she's 16, I thought it's worth giving her at least 10 years. Right, with that introduction, most hip arthritis comes from pediatric diseases that we miss or did not treat correctly, right? Dysplasia, FAI, or scapula. If you have arthritis already, the results are not going to be very good with hip preservation. So you want to prevent or at least slow down the arthritis. In my book, if I can get 5 to 10 years in a 16-year-old with the preservation I do, I think I'll save them 1 revision in their lifetime. Less than 2 millimeters of joint space in functional use is probably too much of arthritis to preserve, right? You should have at least 2 millimeters, or towards grade 2 arthritis. In DDH, if you have high geometric scores, which I don't know how to interpret exactly, but if the space improves, so somebody starts off like this, they have good space. There's no question I'm going to preserve this step. But if somebody comes out like this, no 2 millimeters. But I'm going to do total hip on this, so I'm going to do an abduction view. This one did not improve, so that's the total hip. This one improved, so I'll try to preserve this. Right? A PAO, femoral osteotomy, some of me say that a total hip will do much better, but not in teenagers and young adults. That is the same. And I'm not really complicating the total hip except for the scar I create, or if I get an infection. The stab will be better shape for your cup now after a PAO than without my PAO. In the SCEPI, they may look terrible, but if the space improves with certain position of the hip, I'll be able to do a corrective osteotomy and maintain the hip function for probably 5-10 years. Postpone total hip. A lot of zigzag deformity. This will complicate a total hip. No question, stem placement. So I don't do this anymore. Now I do a neck osteotomy. But the stem is not, the shaft is not affected. SCEPI again. Bad SCEPI in the back. No joint space on there. It's rubbing, getting damaged. Heads back on the neck. No joint space. So this one is corrected. Joint space is thin, but hopefully I'll get 5-10 years out of this. In FAI, if your subchondral bone, like the ones I showed you earlier, where it can go into subchondral bone, there are options to excise the subchondral bone or do microfracture. And if I excise it too much, I'm going to do a PAO to correct that. So somebody like this, not too bad, but somebody like this, or lost a lot of cartilage, I can do microfracture, but you know microfracture doesn't have a very good track record. So I can excise this whole thing, right? Excise it completely. I call them dysplasia, and then can do a PAO on top to correct it, right? Here labral repair is being done, excise it, and then if they're unstable, we'll do something. If you don't have established cartilage, right, it can still be preserved as long as the femoral head is there, right? Somebody dislocated, head is okay, you know, there's capsule, there's no establishment to real do. This was the capsule, right? Now this capsule is right in between now, like that. Dreamed up the establishment, colon arthroplasty, came back to be favored with good head. Same thing. I've done a couple. You can't tell that they ever had anything done. That looks almost like a normal head, colon arthroplasty. This is a little more complicated. Head was too big, not complete dislocation. Head was reduced. It's not my own case, Professor Ganz's case. Bone grafting, and then colonna, the capsule on top. Bumps like this. Chiari is an option to save this hip. This one is a head reduction after, I should have the pre-op, I don't know what happened. Yeah, anyway, this is a bad head. Oh, okay. This one, right, I could have done a Chiari or a shell, but I chose to head reduction, right? I got good joint space, so save the hip for a little longer. Chiari and the shelf don't improve range of motion. This one improves the range of motion. Something like this, there's nothing we can do to save it. So totally not a bad option if they're old enough and the correct patient. But the alternative strategy is to do a pelvic support and Ilajrao lengthening. I've been doing a few of these now in India. I don't have follow-ups yet, but it's not a bad option. I think we've been arguing in the hip thing about THR versus this. There's no implant, probably one-time surgery. They will live for sure. They're not going to be perfect, but they won't need too many repeat surgeries is my hope. Lastly, arthrodesis, just to mention it, I don't do it. Arthrodesis causes a lot of back pain and a lot of knee arthritis, so I don't do arthrodesis. Man, I finished too long. I should be able to give him time to go back to my video. Thank you. I'm going to ask, especially in the part where I led, people prefer arthroplasty for okay, if you see the projection in the Western societies, in the next 10 years, we'll have, there's a
a predicted increase of 52% of total hips will be done in the younger patients. And especially there's going to be a marked increase, and that's what I'm seeing in my practice, between 46 to 50 years old, very young patients. And the more you do there, you're going to have an increase in the, dramatically, the revision you're going to perform. As the last speaker also alluded to, most of these young adults have got dysplastic hips. That's what you're dealing with. You're dealing with SUFE, you're dealing with dysplastic with not many bone around, and we've got congenital abnormalities. Hence, they got early arthritis in their hip. So, if you look at the long-term papers and the outcomes of the of total hips, there are only two papers which you can find, especially below 55 years, and one of the studies have reported less than 63% survival rates at 10 years, which is very alarming. But if you start using biological techniques with infection bone grafting, then your survival rates will increase to 87%. So when you want to do surgery, you're looking at pain, severity of pain, pain at rest, pain at night, and pain with activity. Your function, your walking distance, the need for a crutch, need for analgesia, difficulty climbing stairs, and difficulty putting socks, and affecting your activities of daily living. So you start with your physical examination, range of motion, your radiographs, and you look at the radiographs about the space preserved. If you look at the NGR data from England, you can see most of the causes for doing total hips in a younger patient using avian, CDH, and inflammatory arthropathy. So what are the challenges we face in a younger patient? Mainly surgical approach, the implant type, cemented versus uncemented, metal or ceramic, head size, ceramic poly or metal on poly. And what approach you want to use? A posterior, direct lateral, anterior, or Watson-Jones, or two incision approach. So you can go anywhere in the hip if you like. But if you look at the studies, I think my advice to a surgeon is usually you should do what you are really good in, what you're familiar with. Don't try to do something new for the sake of it. And most of the study shows good outcome with any approach. And that's what in UK people are doing. And most of the people are now going posterior, but they're still lateral and hardening. And you can see there's a marked decrease in traumatic osteotomy and very few people doing anterior approach. So what implant do you like to use? Short stem, long stem, HA coated, what cup, what are the best performing hips? But if you look at the NGR data, most of the implants on the data are doing very well. So you don't have to get confused in all this literature. And these are my patients, you know. And if you want to do hip arthroplasty in a younger patient, you should be able to offer them everything, from hip resurfacing to a cemented hip, uncemented hip, reverse hybrid. I usually do a dual mobility and a fracture neck femur younger patients, short stems, very short stems, neck holding short stems. And if you look at the NGR data, again, there's a decrease in cemented hips, there's an increase in hybrid and uncemented hips. And these are the plants you should avoid. These implants have failed and they should not be used anywhere, to be honest. So that's the good thing having a good joint registry. You can take the bad performing implants out early and the surgeons are aware of them. So all these implants are no longer available in the UK. So especially if you're going to use cement, try to use antibiotic-loaded cement. That's what most of the surgeons are using. The next is head size. which is a low imaging study where you can see a three-dimensional picture of the patient, especially who've got spinal deformities, where the cup placement can differ. So this imaging has been started, and a few hospitals in London are using it now. And you start looking at the results, even on metal results. This is a Nordic study showing excellent result at 96% at 12 years on metal patients. This is one of our leading tennis player, Andy Murray, who won Wimbledon, had recently had his hip replacement. He had a hip resurfacing and he's back in playing tennis, professional tennis. And this is the new study has come on. This is a 3-year-old study by Derek McMinn. They are doing a poly and ceramic hat, metal ceramic hat. But so the result is very new. The first published result is only 3 years old. But overall, if you look at the hip arthroplasty, most of the hip replacements are doing well. So you've got over 50% survival if it's done right at 25 years. So that's the take-home message. So if you do an implant well, it's going to last longer than you think. And most of. So what's your take-home message? If you've got a high-functioning patient who wants to do activity, sports, you can consider hip resurfacing, but do have a chat about metal ions. Any approach, do an approach you're familiar with. Use any implant you want. Personally, I like to go for uncemented, short stem, poly ceramic, 32 head size. Thank you.
This particular topic is a very basic topic. Hopefully, I bought this particular study which has been done in my unit so that with the concept of Ballari conference reach the rural, and also gives a lot of where the resources are very less, we can apply this very simple method and predict the size and reduce the complications. I think we all been in a situation once in our career life that we have come across these complications. Either the dislocation which has happened here is multifactorial causes, but one of the cause may be inappropriate sizing, inavailability of the consignment or the implant which you wanted to have, then you may face this. On the other hand, you have a protrusion as secondary to the implant size, which has been big. So we always face this particular problem in our rural setups here in India. When I was a postgraduate in Wenlock Hospital, we always been having this type of complications and problems and challenge faced. And I know this is a quite challenging issue here with us. And this is not only can be applied to the hip hemiarthroplasties, even you can apply this particular method in other implant measurements as well. So, is this a particular problem everywhere? Even we face this problem, and why we wanted to look into this particular aspect, sizing in a non-standardized X-ray, comes from our own experience. I've written, sorry, is a problem at home. Home is here, but what I meant is in UK. Yes, we had a problem. What happened is, we had a few hemiarthroplasty requiring fracture neck of failures in elderly came in a bulk, and then we wanted to do the operation in a single day, but which is not possible because of what we found out is no consignment available of a particular size. If there is no size availability, we can't take the patient for an operation. So, is there any consequence of this? Yes, a delay in surgery can have increased mortality up to 10% in elderly group, and that increases even if you don't do it within 36 hours, which is the NICE guidelines in UK that we have to do in a particular time. And we also have faced the similar type of a problem even here. The same thing applies even if we don't operate our elderly patients in our setup here in India. we might face mortality and morbidity. So this has led to us to look into, and a small audit, what happened to our whole patient group in 18 months. So we collected about patients requiring hemiarthroplasty of 18 months period. So we found 784 patients, and then we just looked into the operating note, what are the commonest size we come across. In females, it was in and around about 46, and in male, about 53 and 54 head sizes. So it is not possible sometimes to have all these sizes when the load of work requiring hemiarthroplasty comes in to have a stock. So is there any, then we thought, is there any more predictable way of calculating in a simple way in a non-standardized X-ray? I'm using a non-standardized X-ray word because majority of the hip arthroplasty surgeries nowadays done on a template basis. We do have a very digital, very sophisticated system available radiologically. You put it on the computer, you calculate everything. So, but in the trauma situation, when the patients come to the A&E, you have non-standardized X-rays. They don't have non-scaling measures sometimes, and it also varies because patient's habitat, the way the patient is being positioned, and also the patient, the distance between the X-ray and the patient where lies on the table. So there are so many variabilities. That's why the magnification changes in an X-ray. And that is very detrimental. If you have to do a calculation of the implants in a non-standardized X-rays, then it will come inaccurate. So that's the reason we wanted to see, is there any way we can calculate the magnification first and then apply that magnification to simple ruling system on your non-standardized X-ray so that we can predict the size. So we went to our radiology department and then I asked them, is there any, can give us a particular magnification you use it. So it varied from 109 to 128% in the standard X-ray. So it is a very large percentage of magnification, so we can't really apply that. So that's the reason we went two extremes. One we took is 110. Before that, this is what I've already mentioned to you, why we wanted to do this study. So what we did is, we took three magnifications. One is 110, 115, and then 118, so middle size. So we collected a random 50 X-rays of intracapsular fracture of neck femurs, which requiring hemiarthroplasties. And usually we use a monoblock system, Exeter trauma system. And we did a simple ruling system on our packs, the widest two areas to measure on the non-injured hip and calculate and then keep it as a reading. And we applied those magnification calculation and did a little bit of a statistical study. It might be a bit boring, but it gives an important message. So when we took 10%, 15%, 18% magnification and applied to it, and we put it in a regression model, and then we put best fitting implant with magnification what we have seen. Then it came, the nearest best fitting would be 118% magnification or 18% magnification. And with root mean square error in and around about 1.7 millimeters. That means if you apply 18% magnification and calculate, that you might get size of 1.7 above or 1.7 below with that range. And we wanted to reduce even that. Is there anything best fitting model we can put it in and calculate, try to reduce this error? And our statistician came with a smaller, another regression model, and then put a formula into it. And also we saw, by seeing this method, how reliable it is in between us or amongst ourselves. So that's in the sample, what we call calculated, what is intra-observer error was just less than 1%. So amongst ourselves 0.9%, and between us up to 9.4% we agreed. So that means it is a quite reliable method by just applying in a simple magnification. Okay, and residual errors, which I already mentioned, which with 0, what you are seeing here is the error. As we come to 118, so we are coming to the lesser margin of error, and we applied another 2 models. One is 118, that is model 1, and model 2 is the one with the statistician calculation adjusting the regression curve, and then our error came down to from 1.7 to 1.4. That is a little bit more precise. So I don't want to bore with this mathematics because this is all statisticians' work which he has done, and with our own mathematics, we, by putting a constant into that calculation, we reduced that error, and we put the line across in the best fitting line, so that our measurements came very closer to the measurements what we have taken on the X-ray. And based on that, what devised is a simple ruler system. So one side you have got your radiographic head diameter, which you have measured, and according to the calculation which I just showed, and then we have put the sizes of the implant. And then if you, for example, your size comes as a 58, then your implant size will be in and around 49 or 50. So you can have a sizes 1 above, 1 below, and then exact size in your consignment, and that makes for the rural setup to buy your consignment in a very limited resources and have an accurate the results of the surgeries. So it's just an example. Here we measured 57, and according to the ruler, it is coming as 49, and the implant which you used fitted exactly and precisely at 49. So this is quite a simple method. It can be used in any rural setup, but only caveat or the difference would be that it has to be adjusted to your own radiology department. You may have to go and talk to them what is the usual standard magnification they use, and then you can apply these kind of formulas to calculate. Even it can be done on the hard copies, and it can be done on your digital X-rays, and it can be done even on your PACS system. So simple ruler system can take you to the accuracy of the your surgery. And this has been recently accepted and published. It's just a small technical tip, but with the concept of our reach rural and our setups, it would be definitely helpful. Thank you very much.
Thank you, Dr. Mahesh. Any further questions?